Welcome everyone to today's program. I am Ayla Ellison, Managing Editor with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after the completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Dan Mickelson is the CEO of Strata Decision Technology and has over 25 years of healthcare experience. Over the last decade, Dan has become one of the industry's high-impact thought leaders in developing the healthcare information technology market. He has been a central player in bringing electronic health records mainstream and has been instrumental in driving standards by serving as one of the original members of the Certification Commission for Healthcare Information Technology and helping to start the EHR Vendor Trade Association. Our second presenter is Dr. Neil Shah, who has been listed among the 40 smartest people in healthcare by Becker's Hospital Review and profiled in the New Yorker magazine, CNN, and other media outlets for his efforts to improve patient care. He is also an assistant professor at Harvard Medical School and the Aragon Labs for Health System Innovation. He maintains an active clinical practice as an OB/GYN that includes delivering babies, providing primary care, and performing surgery. It is now my pleasure to turn the floor over to Dan to begin today's presentation.
Thanks, Ayla. Appreciate the introduction, and it's great to be on the call today with Dr. Shah. And the one thing I'll tell you that was not in his bio is that he prefers Neil versus Dr. Shah. So I'll refer to him as Neil because that's the only way I know him. But Neil and I have been collaborating for a number of years, have become really good friends, and we love talking about this topic. And it's become an even more relevant topic given the announcement by CMS on Monday regarding taking cardio down the same path as ortho bundle payment, and we'll be talking about that as we go through the conversation. But before we got started, Neil and I had a question for the audience, so here's that question. And this is just to get a sense for who's on the call today.
Yeah, and the question is just, what is your role in your organization?
So for those of you who are just calling in, the three options are financial in a provider organization, clinical in a provider organization, other in a provider organization, or vendor. So we'll wait a minute for the poll here. Okay, and once again, for those who are calling in, Ayla, maybe you could read the results.
Absolutely. So the question was, what is your role in your organization? And it looks like the majority of 56% are financial provider organization. And then it was other provider organization. Next would be a clinical provider organization. Oh, I'm sorry. Fourth or third would have been vendor, and last would be clinical or provider organization.
Thanks, Ayla. And one of the interesting things that we're seeing is that there are clinicians and those in finance and those in operations now coming into that same conversation. And that's really why we're having this conversation today. Neil has been really front and center at trying to normalize the conversation around cost. So let's jump in and talk a little bit about the problem, and then we'll talk a little bit more about Neil's organization. But the story here today that we're talking about is a real big one. So $3 billion in terms of big. So we've all heard the stats that 1 out of every $5 in this country from a GDP perspective are spent on healthcare. The number's at $3 trillion. CMS estimates that will be $5 trillion within the next 10 years. So we're facing a crisis, and I think those of us who live in healthcare, and I've lived in healthcare for now 25 years, really are compelled by this question, which is what will we tell others we did to fix it while we had a chance to do something about it. And really we're hoping this conversation today helps advance the answer to that. Healthcare is really changing. I referenced the direction that CMS is heading in, but everybody knows the same thing is happening on the private payer side as well. So there's an enormous shift going on in the market, and I think the way that we could look at it is from an opportunity or optimistic perspective is it really is perhaps the greatest socioeconomic opportunity of our time, an opportunity to really do well by doing well. The reality is, if you were just to break it down and simplify it, this is the first time the business model of healthcare is changing since post-World War II. So that's going to create a opportunity or challenge, if you want to look at it that way, over the next 10 or 20 years. This isn't a 10 or 12-month thing. There's a lot to be figured out, and there's a lot of confusion in the market. So the conversation or our premise for today is that everyone agrees that as we migrate to a value-based system with risk-based models like bundled payments, gaining speed, hospitals and health systems are going to have to reduce cost. It's the elephant in the room. But the big question is how do you actually reduce cost if you don't know where your costs are to start with? And we'll share with you some great data points that show how big the problem is, but also how big the opportunity is as well. So I'll turn it over to Neil.
Great. So one of the ways that Dan and I thought about how to collaborate and bring clinicians and financial managers in particular together around this issue was to just ask people. This was very much rooted, I think, in our own lived experience where, generally if you're trying to get a lay of the land, what's going on, crowdsourcing is a great approach, but I found that really in every quarter of the healthcare system, when you ask people on the front line what's going on, whether it's the unit clerk outside of the ICU, or it's the medical student even, or the senior physician, or even people who are working on the revenue cycle stuff, about a couple of simple low-hanging fruit opportunities to provide better care at lower cost, they can tell you. And they don't just have one idea or two ideas, they can usually give you a list. But for whatever reason, we had the sense that not only were a lot of these really great ideas not percolating into the public discourse, but really they weren't even being shared necessarily within the organization. We had clinicians and finance folks and others who were working in silos. So Dan and I and Steve Allegretto, who's sitting next to Dan off camera at Yale New Haven, and HFMA, so we got together and put together this story contest, we call it, to try and source ideas to provide better care at lower cost. And Dan, do you want to maybe tell them a little bit more about that?
Yeah, sure. So the story contest ran over the course of about 6 months. We got lots of great ideas. We've actually open sourced those ideas, and we'll have made those available via a white paper on our website. So if anybody wants to download it, they can go to stratdecision.com. But the interesting work that Neil had set up at costofcare.org is to get physicians talking to physicians about cost. So we'll talk about that perception today, that physicians don't know or don't care about cost. And it turns out that premise actually is not true. And I think it will add to maybe some of the interesting parts of maybe busting some of the perceptions that have been out there in the market. So Neil, maybe tell a little bit about cost of care and kind of the work that you guys have been doing.
Absolutely. So I think the story contest, in many ways, it was less about even the specific ideas and more just validation of what Dan just said, which is that the ideas are out there. Even though this seems like an enormous, really complicated idea, when you actually get closer to the ground as opposed to being at 10,000 feet, the solutions become a little bit more clear, and even more so when you bring people together. So about 7 years ago now, I started an organization called Cost of Care that was really premised on this idea. And honestly, it started when I was a medical student. Every third-year medical student gets the opportunity to rotate through the different parts of the hospital, and it's kind of like anatomy for the health system. Like, if you think about it, it's really the only opportunity, at least that I've gotten in my career, to open every single door in the hospital and try and figure out what's happening inside of it. And what you see pretty quickly, and I think everybody that probably works in the system goes through this to some degree, is you see, the extent of our capabilities in medicine, and it's really inspiring. You're like, wow, we can, cure really difficult diseases, and we can take care of really sick people. But then you also see the full extent of our fallibility. And what we've seen is that as the healthcare system has gotten more and more capable, it's also gotten more complicated, which means there's more opportunities to screw it up for people. And so this is an organization that's really been trying to curate the insights that exist on the front line, and then hand them off to well-positioned stakeholders. We've got an advocacy effort that does a lot of that coalition building. We've got an education effort that tries to get clinicians the skills and the knowledge and the tools that they need, and we've got an implementation effort that tries to work with health systems on engaging their clinicians. Because at the end of the day, what we've found increasingly, and we might talk more about this, is that clinicians have got a lot going on. They don't care about cost necessarily in and of themselves. They care about the well-being of their patients, though. Dan mentioned that this is the first time since the post-World War II era that we're starting to see the business model of healthcare change. This is also the least affordable healthcare.
I think we may be
last
losing.
half century.
Oh, there we go. I think we lost you for a second there, Neil. Yep, you're back now.
Oh, well, I was just making the point that 2016 is the least affordable that healthcare has been in the last half century. And that might be the reason why this is the first time we're starting to see the business model change.
Yep.
We can move on.
Great. Okay, so to make it real simple, the old math is, and this is post-World War II, right? So as soon as the federal government made the decision to allow insurance coverage to be pre-tax and to be a benefit during wage controls in World War II, that launched the insurance industry. So in the decade from the 40s to the 50s, we went from 20 million Americans to 140 million Americans on private insurance. And it turns out Medicare and Medicaid only added initially about 40 million people. So the two together created a system where success was really born around quantity, and I think everybody knows where this is going now. Really, it is a two-part equation, right? So value in the future, to the extent that that is the currency, will be this combination of quality, and that's not just clinical quality, but it's also the experience of the care and the satisfaction of the care divided by cost. And so if that really becomes the currency, and I think most people believe it is, how would a finance team structure themselves or support their organization if they don't have data on either one? Electronic health records have introduced quality data over the last decade, so we've gone from roughly maybe 15 to 20% of clinicians having access to an electronic health record a decade ago to around 80 to 90% today. So an enormous change and an opportunity to really leverage that data. But on the cost side, it's mostly been crickets. That data really doesn't exist. And the conversation is a confusing one. When people talk about cost, some people are talking about charges, some people are talking about price, some people are talking about reimbursement, and some people are talking about direct cost. So until that conversation is normalized, it's hard to know what true value actually means. And I had an opportunity to speak at a Becker's conference a few months back, and jumped in on a few of the other presentations. And from what the speaker of one of the largest healthcare systems in the country, an executive, one of the executive leaders for that organization, from their analogy, I drew this picture because I thought it was really helpful. But the way that he said that he describes to his 20,000 employees how healthcare has worked and how it will work is really like this. There's a door, and for the last 30, 40, 50 years, we put a basket at the door. And when people come in that door, they put $1 in the basket. And the more people that come in, the more dollars we put in that basket. And the more we do, the more dollars go in that basket. So really, the strategy, if you will, has been to drive volume. People can use different words to describe it, but that's really what's been happening. And now he said the only thing that's changing is this. That there will still be a basket at the door. But the difference now is that there's going to be all the money initially in the basket. And what's going to happen is that every time someone comes in the door, we're going to take $1 out of the basket. And the more we do, the more dollars we'll take out. The tricky part is the quality has to go up while we're trying to figure out the economics that goes with it. So it's not an easy thing to do. But obviously the incentives and the programs and the roles and responsibilities and the competencies and the information systems that are required in the first example versus the second example are fundamentally different. And that's the anxiety everyone's feeling in the market and what's feeding, the confusion. And that's really what we're all trying to work through. So you couple that change in how you're compensated with this fundamental change, which is that inpatient utilization, which used to be the cash cow, is consistently going down. We all know there's a shift to the outpatient setting, but between a change in a payment model and a change in volume and everything else that's going on around it, this is a challenging time for many. If you look at the landscape change, and this is a pretty powerful image here, this is basically just showing only 3 years ago the way that the U.S. looked in terms of insurance coverage, right? So if you look at the dark purple there, which is most of the map, it shows that more than 16% of that individual community was uninsured. And now look 3 years later, or 2 years later, what that map looks like, dramatically different. So for those of you who aren't seeing it, there's just a couple states, and I think you would know those ones who didn't accept the change in Medicare coverage. But obviously the number of Americans covered now is changed dramatically, and that's putting a lot of pressure on the system to adapt and to be able to treat people at Medicare and Medicaid margins. So the path for today's webinar really are the following points, and we'll walk through these as we go through the rest of the conversation here. Physicians have been in a tough position, trying to create this balance between doing too much or doing too little. The evolving role of clinicians is that they are becoming not only stewards of the patient, but also stewards of the system to an extent, and we need to be able to support them in doing that. It turns out that physicians don't know, but they do care about cost, and unlocking that is an enormous opportunity. To understand cost, you have to understand cost. So a lot of people have started to talk about cost accounting, and we'll talk about how that plays into the equation. And if you're going to measure value, you can't just look at cost. It's really about combining clinical and financial data and looking at it together. It's the only way to truly measure value. You can speak to this.
Yeah, so I think my role is probably primarily to just complicate or add some nuanced context to how physicians think. That's usually my role when I'm hanging out with Dan. And everything that Dan said is absolutely correct. And the thing is, if you've been given this seemingly impossible task of trying to improve quality with less resources, there's no way that you can do that without bringing clinicians into the loop and without also bringing cost data out on the table. So let's talk about that a little bit. This is my graph that's meant to try to explain the entire last half century of healthcare with like one slide. It's like really ambitious, and I think it's the only graph I have. So capabilities on the y-axis, times on the x-axis, and there's basically a line, right? And basically what it shows is that we're directionally correct in healthcare. The left-hand side is like, that post-World War II era. Dwight Eisenhower actually, when he was a president, has a heart attack when he's in office, and they tell him basically to sleep it off. They prescribe a month of bed rest. And the thing is, it's cheap, doesn't cost a lot of money, but doesn't really work either. The right-hand side is like 2016, where if somebody has a heart attack, whether they're the president of the United States or one of those people in a purple state where they don't have insurance, but they show up in the ED, what I guarantee you that they'll get is an angiogram, a beta blocker, and maybe even a stent. So we'd spend $20,000 extra on their care, but they'll live 10 years longer, right? And so the story is, over time, we're spending more money, but we're getting something from it. And we'll talk more about this maybe if it comes up in the conversation, but every couple of months there's a new capability, there's a new technology that blows my mind that's mostly directionally correct. Now, the problem with being directionally correct in healthcare, or at least the reason why it's not good enough, is because it means that you're getting things right on average, right? And as a clinician, getting things right on average isn't good enough, because some of your patients, first of all, no patient thinks that they're the average patient, but the average means that sometimes you're doing too little and sometimes you're doing too much, right? And the thing is that people get hurt both ways. And for physicians, physicians in particular, the last 20, 30 years, everything that we've done to try to make people better off has been aimed at solving the problem of too little. And this is really important. The entire patient safety movement is like the checklist in the operating room. It's about getting people to do more things. But what we've failed to realize is that people get harmed both ways, physically and financially. And we have no existing systems right now to deal with the problem of too much. And I think what we're starting to try to think about with putting cost data on the table and also bringing physicians into the loop is how we solve that problem. We can move on. Right, that's good. We can pause here. We can go there. Okay, so basically this is meant to show that in 2016 physicians are under tremendous pressure to do a lot of things, but the cost component is becoming increasingly palpable in my clinic. You know, I'm a part-time doctor, but every Friday I see like 30 pregnant ladies in the office. There's like no moment in your life where you're more discerning about your healthcare choices or really your life choices than the moment when you're pregnant. And I can tell you that over the last couple of years, it's been different in terms of the amount of patients that come in and want me to engage with them about the value of what I'm offering. And the pressure on me, you know, there's been top-down pressure from policymakers for a while. You know, people that were around in the 90s remember the managed care era in 1994. What's different about this era, you know, even though there's just a DNC convention with the Clintons on the podium, the big difference between what they tried to do in the early 90s and what's happening now is absolutely the role of patients, right? Patients want this. There are more people insured, but they have worse insurance than they used to have. Their average deductible in this country is several $1,000s out of pocket, and you combine that now with the expectation for transparency, because if you go on Yelp or Travelocity, you can get transparent cost and quality information for every other thing you purchase. So why not for healthcare too? This is what my 20 to 30-year-old patients tell me. We can move on. Many of you probably recognize the TV show Scrubs. It was an awesome show. It was funny for the most part. There was a moment where I couldn't watch it anymore, and that was, of course, when I became JD, the intern. Because everything that makes the show funny is like this really perverse relationship that they have. And I put this slide up to remind myself of the fact that it's not just that, you know, I'm sure many of you, I know we've got about 10% of people here who are clinical, but the lion's share of you are not, and I'm sure that you find talking to the clinical folks frustrating when it comes down to financial conversations or really anything that has to do with resources. And part of that reason might be that we're not really taught anything about healthcare costs, but the much bigger reason is that the way that we're taught in healthcare as clinicians is almost as important as what we're taught. The way that we're taught actually teaches us to be terrible stewards of resources. If you think about it, no other service industry would tolerate the levels of paternalism and opacity that we tolerate in healthcare. And you know, when you come in and you get trained as a clinician, you just sort of normalize that very quickly. When you're being chastised by Dr. Cox as the intern for messing up, you're always being chastised for the things that you didn't do but could have done, and you're never being chastised for the things that you did do but didn't have to, right? And of course, people get hurt both ways. When you're talking about resources, that's the whole ballgame. Move on. Now, the challenge is in doing the crosswalk and having these conversations is that every healthcare cost conversation that we engage in at the health system level and even at the institutional level is abstract to a doctor, right? Because we know that 20% of GDP, like Dan said, is a problem. Like, we're smart, we get numbers. We know that $800 billion of waste is bad, but that doesn't really tell you how to take care of the patient directly in front of you. And so we have to start figuring out how to do, especially given deductibles being so high, is how to reframe cost conversations within the doctor-patient relationship. Right, so this is a New York Times CBS poll from December 2015. It's an annual poll that was conducted. What it shows is something that is absolutely remarkable compared to where we were just a couple of years ago. So turns out, you know, when I was a medical student, I was taught that not only was I not taught anything about healthcare costs, I was taught that I shouldn't think about healthcare costs because patients don't want me to. You know, because if you think about costs, you're going to be skimping on care. And that's actually not true. 80% of patients think that their physicians or their clinicians should be talking about costs with them. Interestingly, there was a similar poll that was done 10 years ago, and it showed that a similar number of patients wanted their doctors to be talking about healthcare costs. It showed that the same number of doctors, if you polled the doctors and you said, how many of your patients want you to be talking about healthcare costs, 80% raised their hand in 2003. And since that time, costs have gone up by 230%. Out-of-pocket costs per worker have gone up by 230%. And yet, we haven't moved the needle on this bill.
Yeah, I just saw some data the other day, Neil. It said the PPO cost for a family of 4 has tripled in the last 15 years. So it was about $8,000. Now it's $25,000. So it's expected to triple again. And we showed this data to our employees, which obviously would mean in the next 15 years, by the time a lot of our employees will have kids, maybe teenagers potentially at that point, it would be $75,000 a year. I mean, the number is unimaginable. So obviously it's front and center for everybody.
Okay, a couple of quick points here. This is a generic American medical bill. I like to put this in front of clinical audiences because you put it up for about 10 seconds and you wait, and then you're like, there are 3 problems with this bill. The first is that these 10 seconds are probably the longest that any of you have ever looked at one, right? The second problem is that, and this is a problem that ends up in the media a lot, is that these prices, at least to the end users, to the patients, and to the doctors, look like they're arbitrarily determined and inflated. I know that there's a rhyme and a reason behind it, but it doesn't look good, guys. And then there's a third problem, though. And then you take those first 2 problems, and they're like, okay, right? And you're like, there's a third problem, and then they lean in a little bit. And you're like, about 1/3 of the things that are on this bill, no matter what bill you pick, this is just a generic bill, but about 1/3 of the things that you're putting on there don't need to be there. You could take them off and get the exact same outcome for the patient, and you may even make them better off by taking them off. And that's totally in your wheelhouse, and you need to own that. And that's where you sort of get their attention. So I think this is an important pearl for starting to engage clinicians around thinking about resources and cost. Price is not something that they control at the bedside. Utilization absolutely is. All right, we'll end here. This is like my day-to-day. So Dan mentioned I'm an obstetrician. This is like the bread and butter of what I do, and it's a good case example for the complexity of what we're dealing with, right? Because many of you probably heard about the Choose Them Wisely campaign, where a lot of the professional societies in medicine came up with lists of things that they agree that we do way too much of. And for many of the things that we do too much of, or the things that we're trying to improve, the targets are super clear, and the pathways are super clear. Like, if you're trying to improve mortality, the answer is 0. You should have 0 mortality. Everybody knows that's the goal. This surgery is much more complicated. So just an FYI, childbirth is the most common reason for hospitalization in the United States. C-sections are the most common surgery performed on Americans. That's true of men and women, by the way. So in the 147 attendees that are on this webinar right now, this is the most common reason that any of you had your abdomen opened, including the men, put all together. Super, super common thing. The challenge is that when I do a C-section, I'm always right. So if I do a C-section and the baby comes out pink and squirming, I'm like, it's a really good thing I did it. If the baby comes out blue and lackluster, I'm like, it's a really good thing I did a C-section. Super easy to justify. But in hindsight, about 50% of them are unnecessary. It's about a 50% margin per case for the payer. And so, it's one of the areas in medicine where it's a huge piece of utilization. There's a huge amount of overuse. It's a really, really clear target in terms of it's a discrete service where we know that we want to move the needle. But then when you're trying to engage clinicians around it, it starts to get really complicated and knotty. And so there may be opportunities to bring this out in the questions, but I just wanted to point out that the majority of healthcare decisions and the majority of the kinds of conversations that you'll be having between clinicians and physicians will be things like this, where it's not black and white, and there are lots of shades of gray.
And Neil, I know we rolled over the introductions quickly, but can you just talk for a second about the work that you're doing with Atul Gawande?
Yeah, sure. So, I mean, we're actively trying to fix this. So it turns out right now in 2016, a woman's #1 risk factor for getting a C-section is which hospital she goes to. It's not her risks. It's not her preferences. Turns out C-sections by hospital vary between 7% and 70%. So I wake up every morning and I think that shouldn't be true. And what should we do to fix it? And it turns out all that variation is not well explained by payment or by medical malpractice. And this is actually important because I think a lot of people conflate payment reform and delivery reform as being the same thing. And a lot of what Dan presented up front was the payment reforms that are happening. Okay, so we've got our burning platform that Dan often talks about. But now the hard work in front of us is to figure out how we're actually going to deliver care differently. And the only way to do that, especially when the goal is better quality at lower costs, is to bring financial folks and physicians together with cost information at the table.
Great. Thanks, Neil. So we got a quick question for the audience.
Yes, so the poll question for the audience is, does your organization share cost data with its physician? We'll give everyone a few moments to go ahead and answer. The options are yes, no, and unsure.
And Neil, as you've gone around the country talking to clinicians, what has your experience been?
I mean, I'd be curious how people interpret this because I think, like, as a physician, as a surgeon, I see my P&L sheet, but what really matters to me, like, that's just like an abstraction. Like, what matters to me is, like, for example, in my hospital, nobody can tell me what the unit cost per baby is. They can tell me, I know what I get paid per baby. I know what, people can tell me what it costs to, like, run our labor and delivery unit. Nobody can tell me what it costs to deliver one baby. And I'd be particularly curious if that's the case in other places, because I think that's very, very uncommon. And I think that's what we're trying to talk about today, Dan, right? Yep. Is getting to that level of granularity.
And based on the poll results for the attendees, it looks like 56% said yes, their organization does share cost data with its physicians, and equal amounts, 22% said no, and 22% said unsure.
Yeah, and and on this point, I think it would be very helpful if you guys who are on the phone and on the webinar, if you can submit a little bit of a clarification on the answer to that question, because it would be interesting to know if you share direct cost information or charge information, because there is a difference between those two. When we talk to different groups about whether they share direct cost information with physicians across all of their different specialties on a regular basis, the answer is a resounding 0, typically. You see this in some cases with orthopedics, with implants or different supply initiatives, but in terms of understanding the total cost and therefore potentially the margin, we don't see it all that often. And so unpack that a little bit just to show you kind of what the opportunity is and where some of the disconnect might be. So this is a study that was pretty groundbreaking. It was published in Health Affairs, which many of you know is the most well-respected healthcare policy journal. But it was a study that was done with orthopedic surgeons at Duke, Harvard, Mayo, Maryland, University of Pennsylvania, Stanford, and WashU. So 6 or 7 academic medical centers. And they asked these surgeons, and actually in terms of research, this is pretty amazing because there was 506 orthopedic surgeons at those different institutions, and 503 actually completed this survey, so they must have had a lot of pressure to get it done from the folks who were involved in the study. But with that kind of response rate, the data is pretty revealing because what they asked them was just estimate the cost of 13 commonly used orthopedic devices. And if you come within 20% of the right number, we'll say that you were right. And perhaps not surprisingly, physicians didn't really know the answer. So only 1 out of every 5 times they got it right. So about 20% of the time they got it right. And that may have been a guess. It may have been because they actually have the data. But we present this data to finance teams before, and you get a little bit of a chuckle when you show this. And then we ask them the question, well, do you think your finance team would do any better? And there's silence. So the reality is it's not like Travelocity or Kayak where you know where to get the information or it's accessible. Really no one knows where to get it, and it's very difficult if you have access to it. But then they asked them this question, which is where the opportunity is. Would you use the cost of the device as a key criteria in the selection of a device, and 80%, over 80% said yes. So the reality is physicians don't know, but they do care about cost. So perception and reality don't match. And because physicians and clinicians, with their decisions, control roughly 80% of all decisions within healthcare, what surgery, what referral, what medication, so on and so forth, care pathway, closing that gap represents an enormous opportunity, just to be informed. And it turns out that when you do present that data, it actually works. So a lot of people have that perception that even if you were to give clinicians that data, they wouldn't either know what to do with it or they wouldn't do anything with it. And it turns out that actually isn't the case. So at Johns Hopkins, and in a few minutes I'll turn it over to Steve Allegretto from Yale. At Yale, they have also taken this step of embedding cost within the order sets. They both institutions, I believe at the time, used Epic. I know they do today. And so that at the point of decision, at least the physicians had access to the implications of their decision, and that drove down test volume by 10%. And I think some people have that perception that at the point of the decision is critical, but the reality is it isn't necessarily. So there's different ways to approach it, either real-time or retrospectively. So at the University of Miami, in a study that was published in the Archives of Surgery a few years back, they just gave the physicians a weekly report that showed the dollars charged to non-intensive care unit patients for lab services, and they saw a 25% reduction. Different approaches, but both were effective in driving out cost and driving down volume.
Dan, the quote I love about these studies, it's Abraham Verghese, the guy who wrote Cutting for Stone. He says, if you're ordering off a menu that doesn't have any prices on it, it's really easy to get the filet mignon every time.
Right.
Basically what's going on.
I mean, and Neil, people have used the grocery store analogy for a long time. Like, so if you had a grocery store, people could come in and you weren't going to charge them on the way out. Isn't it possible that they would pick the highest cost item, and isn't it possible that they would consume or grab more than they needed? And isn't it possible that a lot of that would go to waste? And isn't it possible that you would need to have bigger grocery stores?
Right.
And that the entire system would end up costing more? And really, that's the system in many ways that we're in today. In an incredibly poor tactical decision of my daughter, Emma, made 2 years ago when she was 14, she let me look at her Instagram account for a few minutes because I'm a tech guy, so I'm trying to understand kind of how it works and what it does. And so I'm flipping through her Instagram, and I came across this cartoon, and I got really excited. I'm like, wow, this explains everything that I've been doing, for the last few years. And she, of course, didn't understand it, so I'll try to explain it to you. But this pretty much summarizes every cost conversation or conversation about cost I've had with hospitals over the last few years. But so it's a cartoon, for those of you who can't see, with SpongeBob and Patrick. And SpongeBob says to Patrick, he says, wow, Patrick, look at all these mattresses. How many do you think there are? And just by looking at the picture, you would assume there's a couple thousand or at least a couple hundred. And Patrick responds, 10. And then SpongeBob goes, cool. And that is pretty much, when you talk about cost in healthcare, when you talk about a device or a procedure or whatever the case might be, any number will do. How much is that orthopedic device, or how much is that open heart surgery? It's 50,000, it's 10,000, it's 4,000. Thanks. There's really no understanding of whether you're talking about cost or charge or anything else in between, or reimbursement. So this is just not a common language in healthcare today for whatever reason. Now we can talk about outcomes because we have that data. So we need to, in the value equation, be able to talk about cost and the value associated with those outcomes. To kind of back that up with some data, if you take a look around and you were to decide, well, what do we really need out of cost data? Take a look at the 4 bullet points on the right. This is really what the state of the market is today. One is it has to be complete. So in the past, cost was just looked at in the hospital environment. We know there's a big shift to the outpatient environment. We know these bundles cover both. So we need inpatient and outpatient costing. It has to be accurate. So costing, the state of the art for the last couple decades, has been what's called a ratio of cost to charges, which is a fictional number based on a fictional number. So not actually an indicative of what the actual cost is. And as you take on a bundle, and you have a set top line, having a clear understanding of what the cost is the only thing that will allow you to understand the bottom line. So using RVUs, using supply-based costing, activity-based costing, TD-ABC, a lot of these have gotten a lot of play. But the reality is there's a mixed methodology that's needed to get more precise and accurate regarding costing. Most people looked at cost maybe once or twice a year. The state of the art really is monthly now. And then costing was a process that took 5 days just to press a button and have the report come out in the past. And now people need that data and it has to be accessible. So if you were to use that definition, you could argue whether you believe that definition is complete or incomplete or whether things should be changed out, but that's a pretty commonly accepted group of requirements. Less than 10% of health systems today have more of an advanced cost accounting solution that can provide that kind of data. Very similar to the electronic health record market about 15 years ago, when only 10 to 20% of hospitals had an electronic health record. So the market's really shifting and the requirements are really shifting. If you're trying to define the difference between those two realities that I just described, this is a chart that at least helps summarize it. Looking at traditional cost accounting versus more advanced cost accounting essentially covers what I just outlined. But really, the game is not about cost. It's about getting cost data, mirroring that up with clinical data, and being able to look at outcomes overall and look at value, and being able to provide that to physicians. Because of the change that's been going on in the market the last couple of years, you probably heard this data before, but about 2% of hospitals, or actually about 30% of hospitals, are at negative margins, and the average margin for a hospital today is about 2%. So hospitals are operating at very thin margins, and as this top-line pressure increases, many have launched cost reduction initiatives. So at Strata, we had a chance to sit down with 100 different provider organizations, and we asked them a simple question. Do you have cost savings initiatives underway? And almost 9 out of 10, 88%, had something in motion. Makes you wonder what the other 12 were doing, but 88% mentioned yes. And the range was between $50 to $400 million on an annual basis. But when you asked them the second question was, have you hit the target? Only 2 out of 10 were even coming close. And then we asked them, why? What's going on? And this is what they said. Well, we really don't have staff to lead projects. And we have clients that we work with, organizations we work with, 600 people with a revenue cycle team, and only 6 people on process or continuous improvement or in their PMO. So clearly those two lines are going to at least come a little bit closer together over time. But no staff to lead projects. Projects don't produce real savings, a lot of soft savings projects. There's a lack of accountability, no ownership. It's difficult to keep track of projects, and it's difficult to quantify and track savings. And the state of the art is calling a consulting firm or have an initiative internally. It's really not run as a continuous process. So cost and margin management will become more of a religion, but it really isn't today, which leads to the next question. So in our research, we found 88% of organizations had an initiative underway. Let's just poll the group and see where they stand.
Yeah, so the polling question is, does your organization currently have a cost savings initiative underway? And we'll give all of the attendees a few moments to answer that question.
Okay, the survey says pretty close. So if you want to read the response.
Absolutely. So 78% of attendees said yes, 11% said no, and 11% said unsure.
Okay, great. So pretty consistent with the data that we have. So in terms of thinking this through, maybe the next question underneath that is this one. So the same one we asked in the prior research we'll ask to the group.
Yeah, so all attendees can go ahead and answer the question of is that cost savings initiative hitting its target?
Okay.
And it looks like the polling, absolutely, the polling results are in, and it looks like 30% said no, 48% said unsure, and 23% said yes, they are hitting their target.
Yeah, so I mean, going back, and I'm a recovering consultant, so I spent the 90s doing process reengineering and patient-centered care work, and obviously this hasn't advanced that much in the last 2 decades, so there's a lot of opportunity there. And what we found is that right now, if you look in the market, a lot of people spend their time doing the math, just trying to do the quantification, because that cost data really isn't available. So the potential, or the opportunity, if you will, is to shift to a smaller circle, right? Spend less time doing the math and spend more time driving action within the organization. That's the opportunity. And when you want to drill in and understand that, having that cost accounting data allows you to do things like this, look at very real data, not charges, but actual cost, and be able to compare physicians directly in terms of how they're performing, and not as a point of vilification or to identify problems, but more as a collaboration and an ongoing discussion about how to drive more value. And the collective call to action, if you will, as Neil said, is there's lots of examples of where people are doing this and doing this well. The future really is here. It's just not evenly distributed. That's the problem. And to find use cases is critical in terms of having the conversation. So where we really want to intend today was to drill into a very specific example, and just so happens that I am at Yale New Haven Hospital today. You can look at the cover article that Steve Allegretto wrote, who's sitting right next to me on the cover of HFM a few months back. He was also profiled in Becker's Hospital Review a few months ago, but they've done some pretty extraordinary work in this area. And just to highlight a few of the points, I figured I would turn it over to Steve. So here you go.
Thanks, Dan, and thanks, Neil. It's good to to be on the phone with you guys again, given this is a journey, and we'll be at this for a while, right, Neil?
That's right.
And again, you take a look at better quality, generating better margins. We found that engaging clinicians, you needed to be able to provide specific data around their specific patients. And what you have in front of you is the chart that we've used historically here at Yale New Haven Health System to take a look at our revenue per unit of service and our cost per unit of service. And it shouldn't be any surprise, as Dan talked about at the beginning, there's been incredible pressure on our revenue per unit of service for those services that we provide for the patients we see. And you can see how it's leveled off from the 2011 to 2015 time period. As a matter of fact, it was actually flat. And then you look at our cost curve, and our cost curves, surprisingly, I don't know how it is for each of your organizations, but it mirrors the revenue per unit of service. And why is it that as our revenue per unit of service leveled off, that our cost per unit of service level off? Well, we happen to have been fortunate that there was a confluence of 4 different things that happened at the same time. But our organization knew back in 2008 that we were going to have pressure on our revenue. So we implemented an EMR across all of our organizations that allowed us to put in protocols that were consistent across our organizations for all of our patients that each of our physicians see and treat. We came up with a definition of quality. So if we wanted to know how many patients had an adverse event and what impact that had on cost, we were per case we were able to do that. And then we implemented the advanced cost accounting that Dan had mentioned. But the key was our clinical redesign work. Neil, you had mentioned how difficult the work of process redesign is, right? Changing the care for your patients. If we didn't have these systems coupled with our clinical redesign effort, finding engaged clinicians who were interested in the care that was delivered, we would not have been able to, come up with the changes in processes that then led to us being able to sustain $150 million. And there you can see the numbers that that I just talked through. You can see that those are the percentages. So next slide, Dan.
So it leads to a question is, and maybe you can read off the question here.
Absolutely. So the next polling question is, can you generate a profit and loss statement for a specific payment with an adverse event? And you can go ahead and answer yes, no, or unsure at this time. And it looks like the polling results just came in, and it looks like 39% of attendees said unsure, 37% said no, and 24% said yes.
Great, and that really speaks to the breakthrough that Yale has had, and Steve, you can talk more to this, but one of the big changes or challenges that people have had in the market is just trying to understand whether good quality is in fact more cost effective, and that's, maybe you could speak to that as we go through this, some of the work that you guys have done.
Right, and so, and Neil had mentioned before, he sees his overall P&L. Does he know exactly what delivering the baby costs, and then how does that vary based on the patients that we see? Because we all know that one patient is different than the next patient. But what you can see is that here's the detail of our $150 million that we saved, and I just want to point out the clinical redesign, that hard work that Neil talked about. You can see that we had set a goal of about $60 million through 2014, and then making sure that was sustained through 15. We generated about $33 million. It may not seem like that was success, but again, our ability to engage physicians and being able to provide the P&Ls at the individual patient level were important in being able to set the foundation to move forward. And you can see that one of the questions that we asked ourselves is, one of the new pieces of knowledge is we always thought the more we did, the more we made. And you can see by this graph across payer, if you look in the managed care side, these happen to be coronary artery bypass graft patients. You can see in a case where there wasn't an adverse event or a quality outcome like a respiratory failure or a punctured lung, we make about $17,000 a case of contribution of total margin. But when there was a quality event, we made $12,000. And you can see that resonates even on the Medicaid side and the Medicare side. So you can see that even on the Medicaid side, where we have a fixed payment per unit of service, we actually made money on those cases where the variation in care didn't include an adverse event. So this new knowledge of being able to look at the more we do, actually the less we make, versus the more we do, the more we made. So we were able to drive that intuition that clinicians have, that quality will improve margin, and that's what this information shows.
Yeah, so this is one thing, and maybe Steve, you could talk to this as well, but so as we've talked to different organizations about this, and Neil, you and I have had this conversation as well, these are really the three things that need to be in place as components, right? So you talked a little bit about tool set today. You guys have an evolving skill set, but it's really the mindset of the organization. So Yale is doing work like sharing the benefit with physicians, embedding costs within order sets for their clinicians, quantifying quality and being able to share that information with the physician. So really advancing this wheel, which really makes the team unique in terms of what you guys have accomplished.
Well, and I think it's all about alignment. Neil, you had mentioned it as well. Being able to have that same common language across everyone that's looking at the patient, both quality and cost side, allows you to share some of that value and have folks who work towards the common purpose, which is improving patient care and ultimately value.
Great, and so I think Brenda and I'll turn it over to you guys just in terms of whether there's any questions.
Yeah, so thank you to all of our panelists for a very informative and enjoyable presentation today. We are going to go ahead and begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A. So I'm going to go ahead and move to the first question, which is, I guess this is a good question for Dan probably, and it is, how do you share cost data without causing animosity between specialties?
That's a really good question. I think actually Steve probably has more experience with that. We were in a room with a bunch of clinicians here today, and so one of the things that Yale has done is created a lot of trust between the finance team and the physicians. I think there's a lot of fear and anxiety that people have, and Neil has encountered this too, that, oh, what will physicians say? And but the point is not to have this finance led, but to have it finance supported. But it has to ultimately be clinician led. But this battle between specialties, what do you see there?
Yeah, again, it comes down, we happen to be meeting with the orthopedic and the heart and vascular physicians today. And one thing physicians understand is there is variation in patient care. And being able to provide that data to the physicians, led by physicians, with trying to look at avoidable variation. Neil, you touched upon it, right? There's a lot of variation in care around C-section rates, and being able to share that data, physicians know it's there, and how do we use that in a constructive way to improve behavior and outcomes?
Yeah, we often talk about it as innings, right? So people are like worried about the ninth inning and what's going to happen then, versus just get on the field and start playing. So if you open up and share the data with clinicians and get their feedback and educate them on what cost actually means, that's the starting point. If you look a decade or maybe 15 years ago, Neil, you could confirm this, but when you talked about order sets with clinicians, they basically said that was cookbook medicine. You don't hear that term anymore, right? And with electronic health records, people initially said, well, doctors are technophobic. They will never do that. Apparently, technophobia has been cured in some fashion. So it turns out both of those assumptions were wrong. This assumption around physicians not being willing or able to engage with cost has been proven time and time again not to be true, and Yale's a good example of that. So I think the point is get over the fear, explain kind of the strategy and the goal, and then engage.
I
Pretty much what you guys are doing here.
Right, I agree.
And I'll concur with all that too. I mean, there's going to be turf wars between clinicians until the end of time. But I think one of the things that we're seeing increasingly is that care of patients is a team sport. That's true at pretty much every level. And when you have data on the table, one of the things you're able to do is benchmark yourself as an individual doc against the one next to you. And so to the person who posed that question, I'd say that's probably your ace in the hole. There's going to be the perennial tension between radiology and everybody else, right? All the cost is in diagnostic imaging or whatever it is. But if you look at patterns of behavior, patterns of ordering for a particular kind of clinician, and you stand it up against the person next to them, that there's literally nothing more effective. And you don't even give them a solution. You say, why don't you guys talk it out? We've seen that in your OR it costs 3 times more than the guy next to you, or this guy is doing 5 times more transfusions than the guy next to you, and just figure it out.
Yeah, and I think people worry about the outlier initially, and they become consumed with it. What will Dr. fill in the blank think, right? So start at the other extreme and create momentum, and then work your way towards that physician versus becoming, that being a blocker by itself.
Okay, thank you all. And we're going to go ahead and move on to at least one more question, and that is, how do you assign the ownership of physician to individual patient cases on the hospital side? There are debates related to primary surgeons, attending physicians, and discharge physicians, considering various providers' involvement when they do handoffs.
That's such a good question. I mean, Steve, I'd be curious how you guys think about this, but it's really important. Just like, I mean, quality of care and patient safety is no different than value. And from a patient safety perspective, if there's an adverse outcome, we always think about it as a systems problem. We go in with that assumption, and we assume that there's multiple things that happened along the way that drove a particular decision. And I think cost and value is the same thing. Now, that being said, whether you're talking about quality or you're talking about cost, attribution to individual clinicians is a really knotty, difficult thing. So I'm not discounting that. And the way I would answer it is, and again, Steve, really curious how you guys do it, but I'd really kind of put that back on your clinicians to sort of figure out, because it's probably case specific, it's at least condition specific, and you probably want to give the ownership of how to deal with that back realizing there's no perfect thing. Like if I do a C-section, I could have just been the one that caught the hot potato, right? I could have just like come on, and it might not be my fault. It might have been like my colleague who messed it up for the 12 hours before that, and that's a real challenge. But we, at least for that particular problem, we sort of worked it out on a department level, and we figured that happens sometimes, but in the end, it'll probably average out.
Well, and I would, Neil, what I would say is that patient care is a process, right? There are a lot of folks involved in that process. In the cost accounting that Dan described is coming up with the total cost for that process, the length of stay, the diagnostic imaging, the radiology. And I think just as you described, Neil, when you put that back in the hands of the clinicians and the physicians, they know what to do with that data. They know how to use that data. So we look at it as it's process attribution versus provider attribution. And in there, there'll be some folks accountable for certain pieces of that process, and that's why you need that cost accounting across all of the departments that provide the services. So.
Absolutely.
Great. Well, we're moving on to one more question, and that is how many finance staff does it take to maintain the cost accounting system?
A lot. No, I'm just no. Actually, I've learned. When you think about it, I always look at that question: how many folks do we have on staff that take care of revenue cycle, and how many folks do we have on staff that take care of charge master? You need a number of those particular folks to. We need to be able, in order to do cost accounting, you need a charge master. But the different view is not looking at it by charge, is looking at it by relative value units, and you look at it from the perspective of the user. If I had to compare the number of revenue cycle folks that we have to cost accounting, we probably have 4 revenue cycle staff for every person that we have on the cost accounting side. And I think that's part of where Dan talked about we went from what was success in the past, it was doing volume. Now we need to be able to take a look at that volume and understand the cost. So I think there's going to be a shift over time, but you need dedicated people to maintain the cost accounting system because that's where you're going to use that data to help drive a change in process.
Yeah, I mean, the common term is now decision support, right? So that's the payer contract modeling plus the cost accounting, so you could do margin analytics. Ultimately, that's what people are going after. And, for a multi-billion-dollar organization, you're talking about 4 or 5 people in many cases, somewhere in that range, depending on what you're really asking that team to do and what the objectives are relative to decision support itself, because that is a much more global concept than just doing a cost study or doing an RVU study. What some organizations have done that are really small is they have begun to outsource RVU studies and other work as a supplement, right? So one of the things that our team does is if somebody needs a cost account for a few days a month, that could be sourced centrally because that's not a competency that really exists in the market today. They're hard to find, people who have experience in that zone. So we're seeing different models, but from an FTE perspective, it's relatively light anywhere you go in terms of the number of people that are needed to support it.
And you really need finance folks that understand the process and can talk with clinicians around what that information means. So, I mean, that's the piece where you need that looked at by service line as well.
Yep.
Well, unfortunately, that is all the time we have for questions today, but I want to again thank our presenters for their excellent presentation and for all the attendees for participating today. We look forward to having you join us for future webinars. This concludes today's program, and have a wonderful afternoon.
Thanks, everyone.
Thank you.
Bye-bye, everyone. Bye, Neil.